Hello everyone and welcome back. So in this video we will discuss the topic congestive cardiac failure and infective endocarditis. So starting from the first topic, we are having a scenario that there is a 4 years old girl who presents with breathlessness. She was well until 7 days ago when she developed a nasty cold and fever. She is progressively deteriorated. Her immunization is up to date. On examination, pulse is 130, respiratory rate 29, BP 80 by 60. She is afebrile and on 25 percentile for height and weight. She has slightly cool peripheries and capillary refill time of 2 seconds. She has loud gallop rhythm and palpable level. Pulses are easily palpable in all four limbs, and chest X-ray shows globular enlargement with pulmonary plethora. Another scenario is that there is a 1-year-old infant who presents with pallor and respiratory distress. Respiratory rate is 100 and heart rate is 180 beats per minute. She also has a gallop rhythm. X-ray tests show cardiomegaly. Echo shows poor ventricular function, dilated ventricles, and dilated left atrium. So we are having the clinical features of that there is breathlessness, and she has developed nasty cold and fever. Immunization is up to date. Pulse is greater. She is febrile and she has slightly cold peripheries and capillary refill is of 2 seconds. She has gallop rhythm. This is the main clinical feature of the congestive cardiac failure and palpable level. Pulses are easily palpable and chest X-ray shows globular enlargement with pulmonary plethora. In the next scenario, there is respiratory distress. Respiratory rate is 100 and she has gallop rhythm. X-ray shows cardiomegaly and echo shows poor rhythm and ventricular function, dilated ventricles, and dilated left atrium. So the diagnosis is congestive cardiac failure, and the investigation options are X-ray chest. That is, X-ray chest shows cardiac enlargement. Pulmonary vascularity is variable depending on etiology of the heart failure. Fluffy perihilar pulmonary markings suggestive of the venous congestion and acute pulmonary edema are usually seen only with more severe degree of heart failure. ECG shows ventricular hypertrophy, left or right ventricular ischemic changes in cardiomyopathies. Low voltage QRS morphology with ST wave abnormalities suggest myocardial inflammatory disease or pericarditis. ECG is best method to evaluate rhythm disorders as a cause of heart failure. Arterial blood gases. Arterial oxygen levels may be decreased when ventilation perfusion inequalities occur secondary to pulmonary edema. When heart failure is severe, respiratory or metabolic acidosis may be present. On echocardiography, assessing the ventricular function, Doppler studies used to calculate the cardiac output. Now, the causes in infants are severe anemia, hemolysis, fetal maternal transfusions, supraventricular tachycardia, complete heart block. In neonates, fluid overload, Quercetin ductus arteriosus, ventricular septal defects, supraventricular tachycardia, metabolic causes that is hypoxia, hypoglycemia, acidosis, anemia, and sepsis, asphyxiated cardiomyopathy, viral myocarditis, and left-sided obstructive lesions. In children, rheumatic fever, acute hypertension, viral myocarditis, cardiomyopathy, cor pulmonale, and severe anemia. These are the causes. Now, the management is general measures and specific measures. In general measures, bed rest, position of the patient, that is semi-upright position at angle of 20 to 30 degree in bed to reduce the venous return pressure. Feeding, that is increased daily calorie intake. Salt restriction, patient admitted. Record vital signs 1 hourly for first 24 hours. Maintain intake output record. Oxygen therapy give 4 to 6 liters per minute. Fluid restriction, that is 75 ml per kg per day or 2 to 3 times of the daily requirement, and treat the infection with antibiotics and monitor and maintain normal values of hemoglobin, calcium, and potassium and pH. These were the general measures. The specific measures are blood transfusion, that is slow packed salt 10 ml per kg. Diuretic, that is furous amide 1 to 2 mg per kg, and the dose is given intravenously 2 mg per kg dose in 2 divided dose. Spironolactone 2 to 4 mg per kg per day in 2 divided dose. Digoxin is given, which is a drug of choice, and the dose is 0.03 to 0.05 mg per kg, and this is the maintenance dose. Inotropic drugs are given, which is dopamine and dobutamine, which is used in when BP is low and urine output is low. Vasodilators are used to reduce the afterload on ventricles by peripheral systemic vasodilation, and captopril is used in 4 divided doses, and nitroprusside is used. These are the main drugs, and this is the specific treatment for the congestive cardiac failure. Okay, so we have discussed the general and the specific measures. So this was all about the congestive cardiac failure. The main clinical feature is gallop rhythm, and it is associated with breathlessness and nasty cold and increased respiratory rate and pulse rate and capillary refill time and palpable liver. So the diagnosis is based on the investigations, and the investigations are extra chest which shows cardiac enlargement, and the ECG shows ventricular hypertrophy, left or right ventricular ischemic changes in cardiomyopathies, and low voltage QRS morphology with ST or T wave abnormalities. Arterial blood gases levels may be decreased when ventilation perfusion inequalities occur, and echocardiography assessing ventricular function, that is Doppler studies which is used to calculate the cardiac output. The causes in infants are severe anemia and SVT and complete heart block. These are the causes of neonates, and these are the causes in children. Then we will provide the general measurement and the specific measurement. In the specific measurement, we are having blood transfusion, diuretics, spironolactone, digoxin, inotropic drugs, vasodilators, which are captopril and nitroprusside. Now coming towards the next topic, that is infective endocarditis. So the scenario is that there is a 7-year-old boy admitted in PEDS with complaints of fever for last 3 weeks. He has been to multiple general physicians but no improvement. On examination, there is clubbing, splenomegaly, and splinter hemorrhages. On auscultation, there is changing murmur at the left lower sternal border. So these are the main features of the infective endocarditis, that is fever and clubbing, splenomegaly, splinter hemorrhages. On auscultation, there is murmur. The main features that diagnose the infective endocarditis is splinter hemorrhages and murmurs. So the causes are Streptococcus viridians for 50%, Staphylococcus aureus and Staphylococcus epidermidis, and Enterococcus H. influenza and Pseudomonas. The investigations for diagnosis is two criteria which contains two major. If the two major criteria are present, then it is infective endocarditis, or one major and three minor criteria, then it is infective endocarditis, or five minor criteria, then infective endocarditis. The major are positive blood culture, positive echocardiogram, and new valvular regurgitation. The minor are prior infective endocarditis, drugs use, fever, major emboli, septic pulmonary infections, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, Janeway lesions, glomerulonephritis, osseous nodes, rod spots, rheumatoid factors, single positive blood culture, and active infections. These are the minor criteria. So if 5 minor, then it is infective endocarditis. These are the investigation options, that is ESR is done, which is usually raised. Leukocyte count may be normal or raised, may be microscopic, or hematuria is present. Blood culture is critical for diagnosis. At least 3 blood cultures should be obtained within 24 hours, and echocardiography localized vegetation. The treatment option is organism-specific antibodies for 4 to 6 weeks, that is benzyl penicillin and gentamicin for streptococcus, vancomycin plus gentamicin for staphylococcus, and amphotericin B for fungal. Surgery is done in case of failing medical therapy, large mobile vegetations, aortic valve disease with unstable hemodynamics, severe worsening congestive heart failure with or without embolization, or persistent infection, and fungal endocarditis. Prophylactically, antibiotics given prior to invasive procedures, amoxicillin is given, and antibiotic prophylaxis is done. Cardiac transplantation is done with cardiac valvulopathy, prosthetic cardiac valves, and the past history of infective endocarditis, unrepaired cyanotic heart disease, and repair of the congenital heart disease is done prophylactically. So this was about the infective endocarditis. The main features that diagnose the infective endocarditis is splinter hemorrhages and clubbing, splenomegaly, and auscultation shows murmur. These are the causes, that is Streptococcus viridans and Staphylococcus aureus, Staphylococcus epidermidis, Enterococcus H. influenza, and Pseudomonas. It is diagnosed on the basis of Duke's criteria, which contain the major and minor points. The major are positive blood culture, positive echocardiogram, and new valvular regurgitation, while the minor are prior infective endocarditis, drugs use, fever, Janeway lesions, glomerulonephritis, osseous nodes, rod spots, and positive rheumatoid factors, single positive blood culture, active infections, conjunctival hemorrhages, intracranial hemorrhages, mycotic aneurysm, septic pulmonary infections, and major emboli. The investigation options are ESR, blood culture, and the treatment options are given according to the organism specific antibiotics, and surgery is provided, and the prophylactic treatment is also done in the case of infective endocarditis. So this was all about infective endocarditis. In this video we have discussed the congestive cardiac failure and the infective endocarditis. So here the CVS chapters end, and this was all about the revision of the CVS. We have discussed the topic, the tetralogy of Fallot, and transposition of great arteries, Okay, the tetralogy of fillet and transposition of great arteries in the first video, and then the ventricular septal defect and patent rectus arteriosus in the next video, and then arterial septal defect and congestive cardiac failure and infective endocarditis in this last portion of the CVS. Thanks for watching.